so much once again to the Endometriosis Foundation of America for this invitation. And I think Dr. Shaking made a mistake because he asked me to make a lecture about the last 15 or 20 years of my life. And unfortunately, I will speak about different things, not just about endometriosis. And if you allow me, I would like to dedicate my lecture to two persons in this room. Two wives. Tomorrow is the day of the woman, but if we were able to do the kind of job we are doing over the last 15, 20 years of our life, is because behind us we have very strong women. And so I would like to dedicate my lecture to Liz, Harry's wife, and to Silk, my wife. So, the evolution from the laparoscopic oncology, because it's true, I'm a laparoscopic oncologist. And for 15, 20 years, I'm a shout-up procedure, so I'm doing vaginal surgery in cervical cancer. And for 20 years, when we start with all this laparoscopy, we have not to forget, you have to keep in mind at that time, because you are speaking about morbidity in the nerves, when you were an oncologist for 20 years and you perform radical surgery for cervical cancer, if your patient was able to empty the bladder after the surgery, you was not a good surgeon. You was not radical enough. You had to have at least 30, 40% of your patient with bladder atonia. At that time, with laparoscopy and vaginal surgery, we had to prove that we were able to do the same as well as by open surgery. And by the truth, we were able to make even more. You see such a specimen, but when you did radical surgery, you have a lot of morbidity. You completely destroyed the sexuality of the woman, the bladder function, the rectum function. And if in oncology, patients are more appropriate to accept this morbidity, in endometriosis patient is not acceptable. You cannot perform a surgery in a 25 years old woman. You do a great surgery and she have no sexuality and no bladder function after. So my way was not to try to reduce the surgery, and I'm really happy that today we have different tools like shaving, discoid, resection, and segmental, but I'm speaking for 20 years before. So at that time, we had no shaving and discoid. So our route was to try to preserve the same radicality, but to reduce the morbidity. And it was easy in oncology, not so easy in endometriosis. And here I start with putting electricity on the pelvic nerves in order to check what happened, because I call anatomists, please come with me in the ward, and please tell me where I can cut, where I cannot cut. At that time, I use a small tricks. I put blue dye in the cervix. That was a big period of the sentinel lymph node, and normally the lymph vessel are getting blue. The nerve are still white. So in my mind, I was looking for the structure where white and to preserve them. So, and when you do surgery, radical surgery, you will have complication. If you do surgery at the pelvic side wall, sometimes you will kill some structure, you will cut some structure. Maybe you will recognize or not that it's a nerve. You will maybe not believe, but before I was able to recognize the sciatic nerves, the biggest nerve in the entire body, like this one, 1.5 centimeter, I had to perform more or less 150 to 200 lymphodectomy until I was able to recognize that is the sciatic nerves. And when I made a big mistake, I called the neurologist and I asked them to help me. I make a mistake, I have a problem with my patient, pain, hypoesthesia, or even patient were not able to move something in the leg. And what I discovered is that the neurologists have absolutely no idea about the nerve in the pelvis. And that was the beginning of the neuropelveology, to recognize anatomy, go back to the root, go to the pathologist and make dissection of cadaver. But much more important was how to make the diagnosis. I spoke yesterday the diagnosis of endometriosis of the sciatic nerve, but you have to be able to make diagnosis of a lot of different pathology of the pelvic nerve, and you have to be able to make the diagnosis of your complication before you send to the patient to the psychiatric, because after the surgery she has something I cannot explain. So it's always the fault of the patient. So we discovered that either neurologist, neurosurgeon, psychiatrist, nobody is dealing with the pelvic nerve for a simple reason. They are hidden in the deep protection of the pelvic bone. You cannot put a finger, you cannot put your needle to make some measurement of the pelvic nerves. And whose neurologist is putting a finger in the vagina of a woman? I don't know one. So we start with the neuropelveology, and then it's exactly what I explained yesterday. When you deal with the pelvic nerve, we are all speaking about pain, 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 pain. But it's not just pain. You have information going in both directions. So if you deal with the nerve, you will have to deal with pain, not just the pain, oh wow, it's painfully, but also with phantom pain, memory of pain, all these different kind of pain. And you have to deal with the dysfunction of the pelvic organ and even the legs. Now, 2014, we founded the International Society of Neuropelveology. I'm now the past president since September. We had now a big congress in Zurich with the first honorary member, and the current president is Axel Forman, from the University of Aarhus. So we have a program, a teaching program with a level 1, level 2, and level 3. Level 1, I spoke yesterday, is how to make the diagnosis with a manual, with some video. We have an e-learning platform. You can learn neuropelveology by yourself at home. And there is an examination, but don't believe that it's easy to pass this exam. If you want to pass it, you have really to learn. You have to learn to come back to the neurology. And you have to keep in mind why I'm doing that. Why? Because all these patients with a lot of pain, huge pain, intractable pain, if we are not able to help them, in endometriosis we found something. We have laparoscopy, we can do something. But suppose you make, sorry, I am provocative a little bit. If you perform a robotic surgery, you have a big scar here, you have a lesion of the part of the genitofemoral nerve, the patient will develop a vulvodynia. If you send patient with vulvodynia to psychologists and psychiatrists, they will explain the lady that she has some trouble with the father, with the grandfather, she has some sexual disorder, and at the end, she will always end in the psychiatry. That is not the way. We have to be able not just to make the diagnosis, but first to be able to recognize that it is a neuropelveologic condition. So the next step was really to make how we have to do the diagnosis in neuropelveology, and by the through, the most important is the patient history. You need 1 to 2 hours to make the diagnosis. But if you really listen to the patient, if you have the right question, at the end of the patient history, you will have the diagnosis, at least which nerve is involved in the pain or dysfunction condition. And then I'm a gynecologist, but I have to check the nerves. And when I want to make the diagnosis, in neurology, you make the diagnosis by putting the finger on the nerve. How to do that? We are gynecologists. And for the all gynecologists we learn also to make pudendal block. I don't send the patient to the radiologist. I can put my finger to the pudendal nerve, to the sacral nerve root. Okay, my finger is not long enough for the sciatic nerve, but we have some tricks. And I can put a needle to the pudendal nerve. I have my own urodynamic testing to check if the patient is suffering from hypersensitivity or hyperactivity. I have my sonography, and I can make a Doppler. And here, for example, I see this patient, she have delayed uterine vessel of the left side. It's a left side pelvic congestion syndrome. And when you check in MRI, you found a May-Turner syndrome, and you have the etiology for the pain of your patient because the delayed vein induces an irritation of the pelvic nerve. And you need sometimes an MRI to exclude, or sorry, you need always an MRI to be sure that when you do laparoscopy, you will not find a tumor. And as a neuropelveologist, we are dealing with endometriosis and the most difficult pathology. But we have also, here it was a big, here on the left it was a big schwannoma of the sciatic nerve. It was between the pelvic side wall and the sciatic nerve. And believe me, neurosurgeons are not able to go there. Also, this patient, it was a sacral nerve root inside the pelvis of the sacral nerve root S2, and the patient had a schwannoma inside the root, terrible pain, and the neurosurgeon sent me the patient because he said, if I have to do something here, I have to resect all the sacral bone. I will not treat the patient, I will cut, I will destroy everything. And here the patient had osteochondrosarcoma of the entire iliac bone. You spoke about endometriosis of the psoas muscle. I'm not afraid to resect the psoas muscle. It's just a muscle. You can resect it. The patient will be able to walk after the procedure because the quadriceps muscle is the most important. Here you see we passed some gingerly through the sacral foramina, and the orthopedists were cutting. Maybe I will go a little bit forwards. We passed by laparoscopy, we cut all the vessel, and then the orthopedists were able to cut from outside, and we remove all the left side of the pelvic, and they put here, that was the tumor, and the patient, the surgery was 6 years ago, and she is still alive and able to walk. So neuropelveology is not gynecology anymore. And now let me go a little bit in the next step, the laparoscopic neurofunctional procedure. In neurosurgery, you have the deep stimulation. You have some procedure where we are putting, when they are putting electrode on the nerve. And we are able now to put electrode everywhere on the nerve by laparoscopy. Here it was on the pudendal nerve, here it's in the sacral nerve root. So I will not go on this topic maybe in 1 or 2 years because we have some study going on. But it's our objective definitively to bring the neuropelveology and the neurofunctional surgery in women's health. We have that in men's health, but we have no neurofunctional surgery in women's health. And if you compare how many neurologists we have and how many gynecologists, we need neurogynecology in order to treat some dysfunction of the bladder, of the rectum, of the sexuality, and maybe even psychiatric disease you can treat with neuromodulation. But that is another story. Now, just once again, the why. Our job, and if I learn something from our colleagues sitting in the front, is the patient of the medicine. They are retired, but they are sitting here in front of us. They are not spending their life in Malibu in the sun. They are spending their life here. It's the patient of the medicine. And it's exactly what I learned from this guy. And patient is motivated by love. We have to love. You have to have emotion for the patient. And when I was a small guy, the best friend of my father became paraplegic. And I saw as a small guy what it means for a man to be paraplegic, to sit all the time in a wheelchair, to have the problem with the bladder, and so on, and to see him dying because of a decubitus. So I have that in my mind. And during my surgery, one day I put electricity during a lymphadenectomy, and I saw, the leg was moving. And up that day, I had the vision maybe to put electricity on the nerves in paraplegic. So that was the first paraplegic I performed a surgery by laparoscopy. It was 2003. It was just for the bladder. And since then, I carry on this way. If you want to treat paraplegic or to bring paraplegic to walk again, you have first to treat osteoporosis. Otherwise, all the bone will broke. Coming back to the anatomy, you have the sciatic nerve here, and when I'm putting electricity on the sciatic nerve, I'm very lucky. I was cardiovascular surgeon before, and I know that the sympathetic trunk, the fibers, reach the leg by passing through the sciatic nerve. And it's very interesting when you are putting electricity on the sciatic nerve, and that is a study we are doing. Oh, I'm sorry. Some difficulty to show. Maybe I will show this way. If you see, in this patient, we make a plethysmography. That means we check not the temperature, but the blood supply when we were performing stimulation of the sciatic nerve. And you see, the legs is in blue color. We switch on the pacemaker, and you will see the blood supply will increase. That means we are treating the osteoporosis and the decubitus. It's clear we have enough evidence that to avoid osteoporosis in paraplegic, it's not just a question to stand of the legs, but you have to stimulate the sympathetic nerve system, and you have already a clinical trial in the University of Aarhus when we start part of this study. So when I start in the beginning with the job to try to put paraplegic on the leg, the surgery, it was plain to put electricity in order to block the pelvic and to block the knee. So by the through to make in-body robotic. And that is a paraplegic. I perform a surgery. You see he's able to go up and to walk a little bit, but it's not the way we talk he's able to walk. You see the surgery is done by laparoscopy. We are putting electrode to the femoral nerve, to the sciatic nerve. It's a surgery from more or less 1.5 hours today. Patient are going home the next day, but I suppose we will be able in the next future to do that ambulatory because paraplegic patients have no pain for most of them. And for several years, I saw that some of the patients, after the procedure, start to be able to control the motion. So not I was able to do that with a pacemaker, but obviously something happened and the patient start to be able to control a supraspinal control, a voluntary control of self-motion. And then I asked myself, how maybe to promote this plasticity of the nervous system or to promote nerve growth. I cannot say my patient, please, you have to think all the day, nerve, please grows again, grows again, grows. I cannot do that. So I try to use something different. I will try to oblige the nerve to do something. And we can do that with pain. When you have pain, the body has to inform you that you have pain. And when you are in rescue situation, survival situation, all information when I'm walking off a piece of glass is no need for me to understand, to become aware that I put my foot on a piece of glass to react. The spinal cord will do that for me. The information is going from my foot directly through the spinal cord, is going directly to the muscle before my brain understands what will happen. That means if I can reproduce this process in paraplegic, I have a way to oblige the nerve to bring information to the brain. And it's exactly what I'm doing with my stimulation. When I'm putting a low frequency stimulation of the nerve, it's very, very painfully for the nerve. But the paraplegic don't feel it because they are paraplegic. And it's exactly what we are doing. We have different programs in the pacemaker, and one of them is a continuous program with low frequency, extremely painfully stimulation for the nerve. And now we have a publication. Now we send it. I don't know if we will have success to the Lancet because to send a paper on paraplegic when you are a gynecologist, It's not easy, but I have 9 years of follow-up today, and when we see that the patient start really to be able to move the legs to the knee by themselves. That is a lady, she is able now to expand, and she was a complete paraplegic for more than 10 years sitting in a wheelchair. And very interesting, the plasticity of the body, because in tetraplegic, they have no control on the trunk. I put my device, my electrode, just in the pelvis. I have no electricity going on the nerve of the trunk, but we observe also a better control, voluntary control of the patient of the trunk muscle. And now let me show the results, what we are able to do. Here you see a paraplegic. I remember you, just paraplegic, complete one. Here this guy, he's able now to go 2.6 kilometers. This lady was 18 years lying down this way. She had a double fracture, a TH complete, and a cervical incomplete. She was tetraplegic. She had a scoliosis because of the car accident. The left leg was completely disconnected, and neurosurgeon made some suturing of the sciatic nerve. Here you see this guy now is able with crutches. This lady, you will see in a few seconds what she is able. At that time, she still have a corset, and that was the first stage. I'm not speaking from I do the surgery and the next day she is able to do that. It takes time. All patients have to train a lot. Look this lady today. Look this guy. He's now able to go down, stair down and up. This lady on the right side now is the same lady now with crutches. She was 18 years lying down on a bed because of paraplegic. Now, here you see our data. That is my favorite. Ladies, you will see what she is able. Complete paraplegic patient. Paraplegic, she was age 8. We put the electrode. Here she starts to be able to move the legs by their own. And now we have a study. Our study is 28 paraplegic patients with a follow-up from at least 2 years. And you see that we have more than 90% of our patients are able to staying up. And 70% of our paraplegic are able to walk again. 28 by the bar only, and 40 patients are able to go with a walker or crutches. And that is a huge difference in quality of life. Less edema, less complication with decubitus and everything. But first of all, she is able to do that. So we have really to carry on. And one of my pupils, Nucelio Lemos, makes the same study in Toronto and Brazil with 5-year follow-up, and he had exactly the same result of 70% of the patients are able to walk again. That means up to today, we have a series with ARUS from 82 patients, with 70% of our patients are able to walk again. You see what she is able to do. Complete paraplegic lesion. So by the through, we have a kind of cure. We don't know up to today how it works. Maybe the electricity is going through the spinal cord fluid. Maybe we have discharge of electricity in the spinal cord. One theory is bypassing the damaged spinal cord tissue by using a lightning phenomenon inside the spinal cord. In any case, we are not speaking anymore from robotic, but from cure. And now let me go in the future of the neuropelveology. That was a paraplegic one day after the procedure. So it's not a big deal. I put electricity of the femoral nerve, I can extend the nerve. And depending from which kind of electricity, I can make an assisted training, I can make an active training where I made the training of the muscle, or I can put an electricity that you have a normal life, and I train the muscle in the background. You don't feel that. So we are speaking from in-body functional electrical stimulation. And actually, we are connected with the ESA, not until now with the NASA, because astronauts in the Mars mission will have to spend 8 to 10 hours per day to train the muscle. We can do that from inside. They have something more important to do than to just train 8 or 10 hours per day. One of the big deals in the Mars mission will be the osteoporosis, because in microgravity, they will all develop osteoporosis. When the calcium is going out from the bone, it will go in the blood, and from there in the kidney, and they will all develop kidney stone. It's sure. And kidney stone is very, very painfully. I show you how maybe to protect these people by stimulating the sympathetic fibers contained in the sciatic nerve. Now, we are in the field of the prophylaxis medicine. All people who are lying for a while have the complication of osteoporosis, loss of muscle, and so on, and so on. If I think both, maybe both need the in-body stimulation here to lose a little bit weight, and here because you have no time to make fitness. So both will need an in-body fitness trainer. Maybe all of us, we will need that in the future. We are sitting here all the day. And more than that, and it's the last part of my lecture, if we are able, there is a principle called sarcopenia. Sarcopenia, that means when we are getting older, we lose muscle mass. And the muscle mass is replaced by fat tissue. When you have a loss of muscle mass, you will have more problem, orthopedic problem, and so on. And one of the techniques of the treatment of the sarcopenia is to increase again the muscle mass. And it's exactly what we are doing. So when we are putting electricity on the nerve all the time, and we increase or we avoid the loss of the muscle mass, by the through, we have a clearly technique of aging control. And this is exactly where we are going. So that means in neuropelveology, I think we are opening the future from bionic people. And all this thing started with a knife. The knife and knowledge of neuropelveology start with the endometriosis, and that's the reason probably why I had the opportunity to have this talk here. 15 years, no more, 20 years. That was my picture for 20 years at the end of all my lecture. And the best I made in my life was to be a father. And I hope I was a good father, but I didn't go a lot of meetings because these two boys are these boys here. And that is my wife sitting here in the room. I thank you so much, very much once again for the invitation, even if I didn't spoke just about endometriosis. Thank you so much.